Now, this section here marks the transition from normal anatomy and wound healing into the actual injury patterns encountered in trauma care. The key objective here is not to simply, again, memorize the names, but it's really to recognize how different kinds of soft tissue injuries present and what risk they actually create. Some injuries remain hidden beneath intact skin and may look minor despite serious bleeding or tissue damage underneath. Others are obvious on inspection, but the visible wound may distract from a more urgent airway, breathing, or shock problem. Now, as the chapter moves into closed injuries and then open injuries, keep linking the mechanism of injury to what may be happening at the tissue level. What findings are likely on your assessment, and what priorities should really guide the treatment and transport decisions. So, closed injuries involve soft tissue damage beneath intact skin. We have a contusion or a bruise occurs when a blunt force damages blood vessels and cause bleeding under the skin without breaking the surface. That discoloration that develops is sometimes called ecchymosis. A hematoma. This is a more localized collection of blood within damaged tissues or inside a body cavity. Hematomas can represent much more significant hidden blood loss than a simple bruise, especially when they're large or associated with a fracture or some type of high energy trauma. A crushing injury occurs when you have substantial force is applied to part of the body. In that situation, tissue damage comes not only from the initial force itself, but also from the ongoing compression that can restrict circulation and worsen tissue destruction over time. Now, the important teaching point here is that the intact skin does not mean minor injury, right? Closed injuries can involve vessels, nerves, muscles, just those deeper structures, even when the surface looks relatively unremarkable. Now, let's move into crush syndrome. So, crush syndrome is a systematic problem that can develop after prolonged entrapment, especially when a body part has been compressed for more than 4 hours and blood flow has been compromised. So, in a severe crush injury, those muscle cells die and release these harmful substances into the surrounding tissues. Now, while the limb remains trapped, some of those byproducts are going to stay localized. Once the pressure is removed and circulation returned, those substances can suddenly enter the bloodstream and create that life-threatening complication like cardiac arrest or renal failure. So this just means that the danger is not over when the patient is freed. In reality, the patient may worsen extremely quickly after that point. So for pre-hospital care, prolonged entrapment should trigger an early concern, really early coordination with rescue personnel ALS request, because advanced providers may need to begin treatment before the crushing force is removed from the patient. But overall recognition, close monitoring, and rapid transport are going to be your central priorities for this patient. Now, moving on to compartment syndrome. Compartment syndrome occurs when the swelling inside a closed soft tissue compartment raises the pressure enough to interfere with circulation. Now, because fascia and the surrounding tissues don't stretch that well, expanding edema can compress vessels and reduce delivery of oxygen and nutrients to the tissues inside that space. Now, a classic finding is pain that becomes worse with passive movement. And over time, the patient may also develop changes in distal pulses, skin temperature, color, sensation, or just motor function. So that is why repeated distal neurovascular assessment is so important when the problem is suspected. It's reinforced here that a broader it's going to reinforce this slide is reinforcing a broader trauma principle. Severe closed injuries can damage internal organs and produce significant internal bleeding. So, a swollen, bruised, or painful area may be the only external clue to a much more serious injury. So the surface may be intact, but the patient can still be bleeding. They can still be losing perfusion and moving towards shock. Closed injuries really require the same disciplined assessment as those obvious open wounds. Now, um, to talk about those open injuries differ from those closed injuries because, again, the protective surface has been broken. That means deeper tissues are exposed to contamination, bleeding, And it may be external and it may be immediately visible. Okay. Now, the four categories introduced here: abrasions, lacerations, avulsions, and penetrating wounds. Each term describes a different pattern of tissue disruption. Abrasions involve superficial scraping of the skin. Lacerations are tears or jagged cuts. Avulsions involve tissues being torn loose or just left hanging as a flap. Penetrating wounds are caused by an object entering the body and may produce like a small external opening despite deep internal damage. So, this classification matters because it helps predict how much bleeding may be present, how contaminated the wounds is likely to be, and whether deep structures may be involved. So, even though open injuries are easier to see than closed injuries, the visible wound should never distract from more urgent threats like, again, airway compromise, a chest injury, internal bleeding, or just profound shock. So an abrasion is a superficial wound. It's caused by friction when the skin rubs or scrapes across a rough or hard surface. Common examples include, road rash or rug burn. The figure here is useful because it really shows both the external appearance and the tissue depth. Right, the surface layer has been scraped away, but the injury usually does not pass completely through the dermis. So, because small capillaries in the damaged superficial tissues are exposed, abrasions often ooze blood rather than bleed heavily. They can be extremely painful because the nerve endings in the region are irritated or often exposed. Although abrasions are often not major hemorrhage problems, they are frequently contaminated with dirt, gravel, or just various debris, which makes infection a significant concern. Now, larger abrasions can also contribute to fluid loss, heat loss. So, your assessment should not stop at the skin surface, right? Because the same mechanism that caused the abrasion may also have caused a deeper blunt injury beneath it. Now, lacerations and incisions are both open wounds, but the pattern of tissue damage is different um, because a laceration is a jagged tear in the skin. It's often produced when the tissue is split or torn. An incision is a cleaner, smoother cut made by a sharp object. The visual on this slide is important because it just pairs a clinical photo with a cross sectional diagram. So, showing that these wounds vary widely in their depth. Some are limited to just skin and subcutaneous tissue, while others extend into the underlying muscle, the nerves, and blood vessels. They may be linear or and regular, or more irregular, depending on the object and the force that was involved. Now, clinically, the edge appearance matters less than the actual depth, the bleeding severity, and the contamination, and possible loss of function below the wound. So, even a wound that looks kind of modest on the surface can hide significant damage deeper in the extremity or the body wall. Now, an avulsion is more severe than a simple cut because soft tissue has been forcibly pulled away from its normal attachment. Um, Often between the subcutaneous tissue and the fascia, which is the connective tissue covering deep structures. The figure just shows that two major patterns. You have complete separation of tissue and tissues that remain attached as a flap. Now, these injuries commonly bleed heavily because multiple tissue layers have been disrupted, and the flap may have a poor blood supply if only a narrow bridge of skin remains attached. Avulsions also carry a high contamination infection risk because the deeper tissue is exposed. So, your pre hospital priority are to control bleeding, protect the exposed area, and avoid causing additional damage. Now, if the flap is lying flat and not grossly contaminated, it can be gently laid back in place and covered. If the tissue has been completely torn free, it should be wrapped in a sterile gauze and then transported with the patient to the hospital. An amputation. So, an amputation is a complete severing of a body part. Now, although extremities are most familiar example, other structures like the scalp, ears, nose, lips can also become avulsed or amputated. The amount of bleeding depends largely on the size and of the part and the amount of muscle and vascular tissue that's been involved. A finger amputation may be controlled with direct pressure, while a large extremity amputation can produce life threatening hemorrhage and rapid shock. A penetrating wound, may, by contrast, is created when a sharp or pointed object pierces into the body. You have knives, bullets, splinters, ice picks, can all create relatively small skin openings with very little visible bleeding, yet still cause major damage to the deeper tissues. Now, when the object remains in place, it is referred to as an impaled object, which is addressed later in this chapter. The main teaching here is that a small interest wound does not mean a small injury. Now, stabbings and shootings. So, stabbings and shootings often produce multiple penetrating wounds. So, the examination has to be methodical rather than just impressions. Expose the patient enough to identify every wound and count the number of holes instead of trying to decide in the field which ones are entrance wounds, which ones are exit wounds. Because that distinction can be difficult in the pre hospital setting, and it's better to be determined later in a more controlled hospital setting. A bullet or a blade may travel an unpredictable path, so small skin openings do not rule out major internal injury. So, when possible, obtain helpful, like scene information, like what type of weapon was used or the number of shots that were reportedly fired. But never let that delay life saving care or transportation. Now, shotgun injuries deserve special attention because multiple pellets can create numerous wound tracks in a larger zone of tissue damage. But overall, careful documentation of wound locations, the patient's condition, and treatment is also important because these cases commonly have legal implications. Blast injuries. So blast injuries are best understood as several injury mechanisms happening at the same time. Primary blast injuries come from the blast wave itself and the sudden pressure changes that it's going to create. This is why airfield structures like in the chest and the ears um, may be injured even when the outside of the body looks relatively normal. Secondary blast injuries occur when debris becomes a projectile and strikes the patient, often causing multiple penetrating wounds. Tertiary blast injuries occur when the force of the explosion throws the patient into another object or onto the ground, adding blunt trauma, fractures, head injury, spinal injury concerns. A patient near an explosion may also have internal barotrauma, penetrating trauma, and blunt trauma all at the same time. Really, that's why blast patients require a careful primary assessment, thorough secondary assessment, and a high index of suspicion for injuries that are not immediately obvious.